Right. I think we'll start. I know there may be many people still needing to finish off work and join. We're going to be recording the session, so people may well watch afterwards. Welcome everybody to the latest in our monthly HTD Centenary seminar series after our summer break. I've been very excited about this one, which is going to be essentially handed over to our wonderful colleagues and friends down at Guy's and St Thomas's Hospital, who run our Hospital for Tropical Diseases Infectious and Tropical Histopathology MDT, which happens every Wednesday afternoon and has done for as long as I've been around. Sebastian can tell us how long it's been going before then. And it's a fantastic opportunity for us to get together with the histopathologists and look at material that we've sent to them or that's come their way from across the UK and sometimes beyond, and bring the sort of skills that our parasitology colleagues and various of us in aspects of infection to try and help work out what the problem is, often in the context where the microbiology has not come up with an answer. And there's going to be a smorgasbord of cases over the next hour or so. I hope you find it interesting. I'm always fascinated and learn so much. It's pretty much the highlight of my month at HTD, so I hope you enjoy it too. We've got Sebastian, who starts first, who's we all wish happy birthday to, it sounds, and is right in the last few weeks of his amazing career in histopathology and tropical infectious histopathology, and we'll hugely miss him. And I think you'll see that when he shares some of the cases with us. We've got his successors, Ula Mahadeva, also at Guy's and St Thomas's, and Alex Polson, who've been taking this on in a very super specialist area of infectious disease histopathology. And maybe at the Q&A later at the end, we can talk a little bit about the challenges of and the importance of in maintaining this as a specialty. I've called it, as you can see, when the formalin doesn't matter, and I hope it'll be illustrated to you how much information we can gain through the histopathology and not just depend on the PCRs and the agars in the micro laboratory, and that's something that we've really learned here. Do please, sort of housekeeping, please make sure you're on mute. Do put some questions in the chat. We will see how we go timing wise, whether it's after each of the talks, give a chance to try and collate the questions and get some responses, or if we're running a little bit late, then we'll try and capture a few of them in the Q&A question at the end. Okay, I'll hand over to you, Sebastian. Do you want to try and re-share your screen?
Thank you, Mike, very much, and hello everybody. This is exactly where it all falls down again. Having opened it, is that it? No, sorry. Cancel. We had a practice run, and of course I have now lost it. So I will have to go back to browse. I'm sorry about this. I don't know why it doesn't work. Oh, here we are. Can you see that?
Not yet.
No, okay, that's the wrong way to do it. Sorry, I beg your pardon.
It's okay.
I don't do this so often that I can actually remember how to do it. Right, I'm going to go back into my hard drive and find the talk, which is sitting here as we did before. HTD slide seminar. So it's now just loading up. Just to answer Mike's questions, the clinico-pathological meetings between pathology and the HTD doctors started sometime in the middle 1980s, whilst I was at UCH. And I, rather like Mike says, I always regarded it as the best meeting that I ever did, and we solved loads and loads of problems in consultation, which was wonderful, because we all bring different bits. What I'm going to talk about is four selected autopsy scenarios or cases, as I was asked to do. I've been looking at Now this should come up now,
I think
right?
it's about to come.
It
It's
is,
a
and
blank
it's
screen at the moment. Yes, you're on. You're on.
good. I wonder if I can make it bigger. I'm going to make it full screen because one always likes bigger things. Right, can everyone see that? Are we
We can.
all
We
happy?
can. Yeah.
Great. Thank you very much. I've been doing infectious disease autopsies since Terence Higgins in 1982, but I'm not going to talk about him. I'm going to talk about something else. So there's a couple of unexpected deaths. Back to Nairobi 40 years ago, new syndromes, and a nasty complication of modern medicine. And all this provides is lessons to try and reduce future mortality. So this one is two related deaths. I mean, the people weren't related, but they're the same diagnosis over the same period. The usual lessons relearned yet again through the coronial autopsy system. Patient 1, female age 49, and this is during the period of COVID, which is very important. And she was found dead at home, decomposing, dead for several days, in October 2 years ago. And the letters on the doormat went back to the 13th of October, so probably about 10 days she had died or was incompetent. We know that she had a COVID test which is negative before that on the 9th of October. We know also, going back to NHS 111 records, that she felt unwell, called them, and they said, you've got a headache, you stay at home, that's part of COVID. And that's the last any contact ever had with this poor lady. Patient 2 is much younger. She died rather suddenly at home, having had a week of headaches, chills, vomiting, diarrhea, and thirst. On November the 1st, 2021, she woke up screaming with a headache pain. Her face then drooped, became slurred speech and coma. This was from her flatmate. And when the London ambulance service arrived, they couldn't resuscitate her. Interestingly, she was positive on a cadaveric nasal swab for SARS-CoV-2. Autopsies. On the left-hand side, number 1, she was jaundiced, liver looked a bit green, spleen was normal, and the brain was swollen and was rather darker than usual. I'm going to show pictures. No hemorrhages to see with the naked eye, heart and lungs normal. Patient 2, the younger one, she also had a swollen brain and a much bigger spleen than normal, but everything else was normal. And the pathologist who did this, because that wasn't me, I did case 1, couldn't make head or tail of what was going on and said, help. And I'm very glad that she did. This is the brain smear I did on the first patient. And you can see winding its way across the middle is a capillary with big endothelial cell nuclei, but lots and lots of little dots and brown pigment material dotted through the capillary lumen. And you obviously know what the diagnosis is going to be. This is a Giemsa stain of a brain smear. Patient 2, I'm not going to show you the brain here, not now anyway. I'm showing you the lungs, and because that's what I looked at first. And it became very evident, looking carefully, that there's little blue dots in lots of the red cells percolating through the lung capillaries. So this is malaria. 2 cases. We're looking at zoites in smear and histology, and of course, from the circumstances of death, there's no pre-mortem blood smears or parasite counts. You want to know what happened? Well, first patient came from Guinea and came back to England, where she lived, via Paris. And it was in the airport coming back. She had the negative COVID test. The other one was a British air hostess who had returned from South Africa the previous week. Neither, as I said, has sought medical assistance beyond one of them calling NHS 111. So really, these are the points. Patient 1, I regard as a collateral COVID-19 death. If it hadn't been for COVID, she would have been diagnosed in a hospital and treated and presumably would have lived. She had well-established brain malaria pathology. The other one was rather more acute. And of course, she didn't have COVID at all. She just had an infected nose, which is what we commonly see in people said to have COVID. They just have nose positivity, but no lung disease, which is what really matters. And she had very rapid malaria progression. And that's shown in the pathology here, respectively. On the left, a well-established thrombotic microangiopathy, fibrin in the capillaries, seen on the left, and some parasites. And on the right-hand side, a ring hemorrhage with a thrombus in the middle, looking like a bullseye. And the rapidly progressive lady has, on the right-hand side, little zoites seen in the brain capillary, but no hemorrhage. And an interesting, rather nerdy point is that no malaria pigment has got into the liver portal tract the liver being on the left-hand side, it's all in the sinusoids. And this tells you how acute the infection was. And the message, you know it much better than I do. I don't treat anyone. It's treatable and curable, but you do have to present first. And COVID had an enormous effect on many other diseases, but including malaria. We had several deaths in London in that period, sadly. Okay, 2 is much shorter. This is a very short contribution to epidemiology, and this goes back 40 years when I was working in Nairobi.
40 years ago, when
40
I was
years
in Kenya,
yeah.
I did a perinatal mortality, and it related.
Oh God.
40 years ago, when I was in Kenya, I did a perinatal mortality, and it related.
I'm
40
sorry.
years ago, when I was in Kenya, I did a perinatal mortality survey with the obstetricians, and we looked at about 500 cases actually, and the diagnoses were as expected: prematurity with hyaline membranes, obstetric problems, congenital malformations, there being no screening. And it related to perinates, stillbirths, and live births who had a large liver and spleen and a very hard fibrotic pancreas. The liver sometimes had the pathology you can see in the top right, and it took me many cases before I realized that it might be congenital. And it related to perinates, stillbirths, and live births who had a large liver and spleen and a very hard fibrotic pancreas. The liver sometimes had the pathology you can see in the top right, and it took me many cases before I realized that it might be congenital syphilis. Once I started to...
Right, well, you saw all that, and I do apologize. I'd obviously extracted those slides from a talk that I had to dictate and send on, but you got the message that that's congenital syphilis, diagnosed purely histopathologically, looking at spirochetes as those little black curlicues on the right-hand side of the last picture. And as it said in the text, I asked the head of obstetrics why this was happening, because everyone surely is screened for syphilis. And he said, no, they're not, but we will start tomorrow. And they did. And I like to think that the syphilis rate in maternity and perinatology has gone down. And important point to make, that was the tip of the iceberg. Most neonates or fetuses coming out with syphilis aren't dead. I just looked at the ones who had died. Case 3. HIV is more complicated than we thought. That's no great surprise. And of course, we all know the tipping point was in the late 90s after the Vancouver conference, and thereon death rates dropped, new cases of AIDS declined, and the drug toxicities, which are pretty fearsome to begin with, were progressively resolved. And now they're pretty safe and don't guarantee, but sort of nearly, a normal life expectancy. But we did see a new syndrome. And this is a very famous face in infectious diseases. It's my old friend Rob Miller. And he and I first saw in about the year 2000, but we documented it in 2002 or 2004, a new syndrome called HIV CD8 encephalitis. And then we finally published 20 years ago our sort of 20-year experience of it with all the cases known in Britain. And I should also give credit to my colleagues in France, particularly Françoise Gray, who contributed to the investigations and the literature on this. Case definition, as I'm sure you probably know, is a dementia syndrome, can be quite rapid or rather slower, with headache, confusion, seizures, and the crucial thing, there's no obvious cause, like tumors, infections, or vasculitis. A typical case on the right-hand side, and in fact, I'll show you her brain in a moment, is an African lady who'd been known HIV positive for many years, on retroviral therapy, well controlled, good CD4 count, but called the ambulance and was in a state of great confusion. And when the ambulance people arrived, they found a totally chaotic house, one child moribund and sadly did die, the other child neglected. She was taken to hospital, as was the other child. She had rapid encephalopathy with cerebral swelling and hyperintense lesions, and despite everything they could do, she died. CT shows uniform cerebral compression because the brain is expanding and no focal lesions. I'm no great expert in interpreting neuroimaging. That's her brain on the right-hand side with a very swollen cerebral gyri. There's another brain with a similar disease a few years later in my hands on the left. Basically swollen brains and nothing else to see. The crucial thing is the histopathology, and CD8E has a case definition pathologically. which is there is cerebral swelling, there is a uniform white, predominantly white matter infiltration of CD8 positive T cells without necroses, without viral inclusion bodies, and with microglial activation. There is essentially no HIV to see on immunostains. There are none of the characteristic features of the classic HIV encephalitis, that is to say, multinucleate giant cells or microglial nodules. And of course, importantly, there's no opportunistic infection, vasculopathy, infarction, or tumor to be seen. And the cases we've now seen 24 are all pretty well the same. The histopathology is uniform. And that's what it looks like. Perivascular T cells and parenchymal T cells there. And just remember, of course, that the normal brain contains no T cells apart from those passing through blood vessels. We can demonstrate they're CD8 positive on the left, and we can show they're activated with CD38, and we can show activated microglial cells with other fancy immunostains. We thought back in the early 2000s that this was only happened occasionally in people who are well controlled with a viral load undetectable. Well, we were wrong there, and the French helped us here too. There were actually quite a lot of scenarios. So we've now got 7, including the original one of well-controlled out of the blue disease, which is what Rob and I call that. Then we have people who were well-controlled, but have got intercurrent infection and their control is sliding. And then number 3, emphasized because it is in fact the most common precipitator of CD8E, is previously well-controlled, but they stop taking the pills and their plasma viral load goes up, and so does their CSF viral load. Then we have a few cases of iris, because the histopathology of iris due to HIV in the brain is exactly that of CD8E. We have a few cases of drug resistance. We have some people who've never taken ART but present for the first time with an AIDS or HIV-related disease, which is this, and then a very occasional case of have the classic HIV encephalitis and CD8E superimposed on top. Much debate as to why it happens. Many people say it's all due to CSF viral escape, which I'm sure you know about. Well, it will explain some scenarios, but it doesn't explain them all, and it certainly won't explain the iris ones. Of course, of great interest is the fact that the vast majority of patients are African. It's very rarely described in white people. So there must be a genetic component somewhere. The practicalities are that when now everyone has heard of this syndrome, if people are thought to have it, and as rapidly as possible, one excludes causes like an opportunistic infection or a tumor or vasculitis. If one can exclude that, it's quite difficult. You put them on steroids. And we know now that this saves lives. People get off their beds and walk out, whereas previously they died of cerebral swelling. And the major message in terms of prevention is the rather simple one of don't stop taking the pills. Don't interrupt ART. Final one. Again, many of you might have seen this case, an organ transplantation medical disaster.
Now, when you think about solid organ...
Oh, no. I do apologize for this. I seem to have taken a talk which I had dictated, and of course I'm not quite sure how to undictate it. I will press on. Mike, I'm very sorry about this. I hadn't realized that this would occur.
That's all right. What do you want to do? Just let it do its talking.
I think let it do its, yes, and it's self-explanatory. If you don't like my voice as dictated, you can all just switch off the sound and read the words. It's all there.
Now, when you think about solid organ transplantation and associated infectious diseases, there are 2 completely different scenarios to think about. The first one, which I'm not going to go into, is the complications of the necessary immunosuppression.
We move on.
But the point in this particular case is not that. It's about infections transmitted in the donated organ, in the donated heart, or liver, or lung, or kidney. It was kidney in this case. Now, many of these in-organ infections can be in a sense, anticipated and tested for. And on the left-hand side is the list of things that are normally done in transplant units. On the right-hand side, though, are the unexpected, uncommon, and very difficult to anticipate. And they include prion diseases, rabies, West Nile, strongyloides, microsporidia, Trypanosoma cruzi in South America, and possibly in Europe from people who have traveled, and free-living amoebae. These come out of the blue. But what I'm going to tell you about now is none of those. It's a new one that hasn't been described. And it derives from the donor and two people who received his kidneys. The donor is a man who lived in squalor. He came to hospital with diarrhea, fever, and confusion. A brain scan at the time was normal, but he became gradually demented and comatose. The two recipients were men in their early middle age with chronic renal failure, and you don't have to read the details of the case 1 and the case 2 chronology to see that they became ill, encephalopathic, and both died on day 17 following receipt of the donated kidney. Imaging of the two recipients showed abnormal areas in the brain with no particular pattern, and the radiologist wisely said, "This looks like encephalitis, but I do not know what is causing it." Both the recipients had an autopsy. Because it was suspected there might be a transmitted infection from the stories so far, it was a rather limited autopsy done by a pathologist who was clearly rather frightened. And all that happened was removal of the brain and eye and one kidney from each patient. Material was kept fresh and the rest was put into formalin. The fresh samples went to appropriate public health laboratories such as microbiology, virology, and parasitology. And what was interesting is that after 2 weeks of investigation, none of the labs could come up with a positive diagnosis. And I was contacted by the head of Colindale, which is the major public health lab in the country, as to whether histopathology might possibly be able to contribute to diagnosis. Here are photomicrographs, medium power and high power, from both the transplant recipients of the brain, and they are heaving with small larvae of worms. And these are nematode larvae. So trying to work out what worms they are and how they got there, you need to know the list of larval nematodes that can be seen in the human brain. And interestingly, there are only 6. Toxocara, Strongyloides, Angiostrongylus, Gnathostoma, Balis ascaris, and Microneba halicephalobis. Now, to determine what was going on here, we could ask questions such as which ones of those are particularly neurotropic, what's their size and morphology, classical parasitology. Crucially, which ones actually happened in the UK, since all these events happened in a person who had not travelled outside the United Kingdom, and which larvae can multiply parthenogenetically, in other words, not sexually, in human tissue. And when you apply the appropriate algorithms, it's pretty obvious they can only be Toxocara or Halicephalobis, because those are the two that occur in the UK. And of those two, it can only be Halicephalobis, because, as I'm sure you know from your life cycles, if you have a Toxocara larva in you, it just carries on being a single larva, in other words, not millions of them, whereas Halicephalobis can multiply parthenogenetically. Now I want to use a remarkable and probable messages from this sad case concern the balance of risk and benefit in organ donation. There are, of course, more potential recipients around than there are donor organs available. But
this is my final slide, and it's a fairly obvious one. I do apologize for the voiceover, but actually it's pretty good. And Ula and Alex have taken this point on board, that all these skills happen over time, and we really do need our clinical ID colleagues to encourage and collaborate, because otherwise it's going to die. So thank you very much for attending to this very short summary of some nice cases, and I look forward to any questions. Thank you.
Thanks, Sebastian, and sorry about your hassles, but we caught it all.
Yeah.
Can I just ask a question? Do you want to say anything briefly about how the kind of malaria post-mortem deaths, how you translate that into the work of the Malaria Reference Laboratory and help us sort of pick up and make some impact on trying to prevent those
Yes,
sort of things happening again.
it's called a phone call. I ring up Anna Checkley.
And because maybe you or Peter might want to explain how we try and capture that information and efforts to try and get the message.
Absolutely. I mean, I am or was the pathologist involved in this sort of constant, shall we say, confidential inquiry review. Peter knows much more about it than I do, of course. And I have to say, I haven't actually had to look at many cases because I'm not quite sure how far this review has gone. But whenever I've had an active malaria case, I tell the relevant parasitologists, so they take it on.
Yeah, just a quick postscript from me. We have now reactivated the confidential inquiry that essentially got frozen due to events of the last couple of years. So unfortunately, there's going to be more coming your way, Sebastian and Ula, because we are seeing more high parasitemia patients since COVID than before for a whole variety of reasons I won't go into now. So it's very much on the travel medicine community to put us out of business and stop the cases. That's failing. So I fear you're going to be analysing more over the coming months.
Well, I'm going to rely on Ula to carry on the tradition because it's her job now.
Okay, thanks. I think we probably need to, thanks Peter also, we probably need to crack on. I hope you're able to stay for questions at the end, Sebastian, but we quite understand if you've got to move on to something else. I'll hand over to, do you want to unshare your slides?
Yep.
And then that will allow Ula to then pick up. Ula, over to you.
Thanks very much, Mike. Can you see my presentation?
Yeah, that's fine.
Okay, great. So the first 2 points I don't really need to make to this current audience, that you all know that infectious diseases are actually becoming more important rather than less important as might have been anticipated some decades ago. And you all know how much your practice has changed in the last 10 years, but I do not think histopathologists generally know how much infectious diseases has changed in the last 10 years. So your treatment now very often depends on the specific organism. It's not enough just to say it's a fungus. And of course, now molecular diagnostics play a part in infectious disease diagnostics, and some of those will work on formalin fixed paraffin embedded material. So it gives us an extra sort of feather in our cap. You may not know that in this country, histopathology training and consultant jobs are based on organ subspecialization. And my opinion is that the histopathology training in this country is now inadequate for safe patient management for infectious diseases because the training is very much focused on cancer diagnostics. The UK does not have a centrally organized or funded system for histology second opinion referral work. It doesn't matter so much for cancers because, as I said, most pathologists are very good at cancers, and there are also established local pathways for referrals for uncommon or difficult cancers. So in most departments in this country, infectious disease histopathology cases are reported by the organ specialist. In a teaching hospital, you may get a pathologist who has been designated the ID person, so quite often a hematopathologist. So we at GSTT, you heard from Mike about how this happened historically when Sebastian moved from UCLH to Guy's and St. Thomas's. So we at GSTT provide an infectious disease histopathology service for the Hospital for Tropical Diseases, and we offer national and in some cases international ID histopathology referral service. So what's wrong with this current model? Firstly, as I said, most cases of ID histopathology are reported by non-specialists who do not have the training to report ID cases safely. And this national ID referral service, this sort of informal service that we have, relies on a couple of us. Now Sebastian's retiring, so Alex and I in one hospital. And in fact, we're not even fully an NHS laboratory, we're part of a limited liability partnership. And this referral service is not funded by the government. It's not integrated with other branches of ID diagnostics, especially molecular diagnostics, which of course is becoming more and more important. And it's completely divorced from veterinary histopathology. So the concept of one world, we're not able to enact that because we are so divorced from veterinary histopathology. Private partnerships with NHS histopathology laboratories are unstable and may result in charging for a referral service. And of course, that puts people off from sending cases for a second opinion. The rapid turnover and shortage of laboratory staff, particularly in London, make it difficult for us to achieve a consistent quality and therefore safety in histochemical special stains for microorganisms. And those are absolutely crucial to us doing our job safely. So if we can't rely on the negative ZN really being negative, or the positive Brocart stain showing fungi actually that being a contaminant, it's very, very difficult for us to do our job safely and to serve your needs. And the other thing is, without government funding and support, we are unable to develop or maintain a wide repertoire of immunohistochemical stains for microorganisms which work on formalin-fixed paraffin embedded tissue. So having sort of set the scene, in 2020, we published an audit where we retrospectively looked at the reports of 457 histology specimens which we had reviewed on behalf of the Hospital for Tropical Diseases over a 3-year period. And we found that in about just over 70%, our opinion did not differ significantly from the original histopathologist opinion. But in just over 20%, we found a clinically significant difference. And in about 7.5%, a difference that was not clinically significant. Looking at those 94 clinically significant discrepancy cases, in almost half of them, the original histopathologist had thought there was an infection when in fact there was not one. In about 20%, they had missed an infection that was present. In about 20% again, we were able to be more specific about the type of infection or more accurately identify the organism or its viability. And in about 8.5% of cases, they diagnosed an infection, but in fact, they had got the wrong infection. We were able to diagnose a different infection or organism. So I'm now going to show you some examples of cases, and many of these are actually not part of the audit. So either before or after, this is something, as I said, 20% of cases, or 1 in 5 cases, we find a clinically significant difference in our diagnosis as compared to the original diagnosis. So here's an example of an incorrectly suspected infection, which is actually the most common error. So this is from a 59-year-old man who had a mass excised from the right shoulder region, a soft tissue mass, surgically, and we were told there was a history of recurrent infections. You can see here at low magnification. Are you able to see my my pointer, my mouse, Mike?
Yes, I
Okay.
did, and now it's gone.
Okay.
Yes, I can
Good.
see it.
Okay, so there's a bit of skeletal muscle here, but you can see here fibrosis, and here we come into the mass, which is partly pseudocystic, and there's a lot of inflammation here. And it was in these pseudocystic regions that the original reporting histopathologist saw these strange and arborizing structures. So you can see here what looks like an outer wall and an inner content, which on the Brocart stain, you can see on the inside these round structures. So they thought this is some kind of helminth or worm parasitic infection. In fact, this is myosferulosis. So this is a false positive, something that once you've seen it, you recognize it again. And this occurs in sites of hematoma, and the red blood cells are what are forming these round structures, and the red blood cell membranes coalesce to form these sort of membranous bags in which the red blood cells are found. My next example of another incorrectly suspected infection was from a 61-year-old man who had had Hodgkin lymphoma treated 6 years previously and now represented with cervical and mediastinal lymphadenopathy. So the original histopathologists had reported this as granulomatous inflammation with mycobacteria. Here you can see the core biopsy at low magnification, and even at this magnification, you can make out that there are paler round areas which actually represent ill-defined granulomatous inflammation without necrosis. There's mixed in other inflammatory cells or lymphocytes and so on. This is their Zn stain, and you can see here clumps of somewhat fragmented acid-fast bacilli. But when we look on the slide off the section, we also find clumps of acid-fast bacilli, which tell us that these are in fact laboratory contaminant mycobacteria or tap water mycobacteria, Mycobacterium gordoni. And in fact, we repeated the ZNs in our laboratory and they were completely negative. What our hematopathologists who reported this case with me, what they noticed was there were occasional atypical cells like these. And in fact, the subsequent biopsy did show a relapse of Hodgkin lymphoma, and therefore the granulomas were secondary to the Hodgkin's and not due to an infection. My third case is of a missed infection. This comes within the category of what I call not seeing. This is from a 66-year-old Tibetan woman who for 2 years had a scabbing and erythematous lesion on her right shoulder. And the original histopathologist, who was a specialist dermatopathologist, had diagnosed a mixed acute and granulomatous inflammation, and they said TB cannot be excluded. So there were a couple of biopsies of skin. In this one at the bottom here, you can see a hyperkeratotic epidermis, and in the dermis, nodular areas of inflammation. And even at this magnification, you may be able to make out that there were lots of giant cells and there were granulomas as well. In this other skin biopsy, you can see epidermal erosion, and beneath the eroded epidermis, these sort of pustular lesions. When we look closer at them, you see a mixture of neutrophils, but a lot of eosinophils. And on one section, at one level, on one H&E, there was this structure, which is diagnostic of sporotrichosis. This is an so-called an asteroid body with the yeast in the middle and surrounded by this radiate Herpes splendori reaction. So by spotting that, we were able to solve a 2-year mystery with this patient. The other thing is that sort of comment, TB cannot be excluded. I would say it can be excluded because with TB, you do not get this sort of very florid eosinophilic reaction, so that even that type of reaction is against TB. My next example of a missed infection is what I call seeing but not recognizing. So this is from a 65-year-old woman. This is a recent case, a CT-guided biopsy of a right upper lobe lung lesion with a PET scan pending. And the original histopathology diagnosis was of non-specific chronic inflammation. And you can see at low magnification, there were 2 cores of lung tissue, and indeed they do show chronic inflammation. But what about this? So this thing, I think the histopathologist must have seen it, but must have dismissed it as some kind of contaminant material within the specimen. But I'm sure you probably also may recognize this as the laminated layer of of cystic hydatid disease or Echinococcus granulosus. So as I said, I'm sure they must have seen it, but if you don't know what you are seeing, it's very easy to dismiss something like this as something foreign in the specimen. My next example of missed infection, another example of what I call seeing but not recognizing. This was one of our local GSTT cases, a 9-year-old boy with type 1 diabetes and an insulin pump. And he had biopsies elsewhere of recurrent skin lesions that were diagnosed correctly as being granulomatous. And we were asked to review them. And this biopsy was from the left thigh. So here you can see we're in the subcutaneous fat. And there's dense inflammation here with tissue breakdown. And this is the pathognomonic lesion, which I'm sure they must have seen, but simply because they had not seen it before, did not recognize. So here's a large epithelioid granuloma with suppuration at its center, so neutrophils, and there at the center of the neutrophils, a large empty-looking ovoid space, but within it, filamentous, the long bacilli, and they are gram-positive and Ziehl-Neelsen positive. And this is diagnostic of non-tuberculous mycobacterial infection. And in this corner here is our BCG immunostain, which cross-reacts with other mycobacteria, and that is also showing positivity in those. So we were able to give a diagnosis of non-tuberculous mycobacterial infection, which is what was clinically suspected but unable to be proven. My next example is where we diagnosed a different infection organism to that which had been originally diagnosed. This was again a recent case, 61-year-old man who had an excision of a suspected basal cell carcinoma from the left anterior shoulder. And the original diagnosis had been cutaneous leishmaniasis. So you can see here a large piece of skin with a central ulcer, and beneath that, inflammation. The inflammation consists of granulomas with large multinucleated giant cells. And as we look closer, you begin to see within the giant cells that there are organisms. So these are what they call Leishmania amastigotes. So even on the H&E, we were able to say that these are not Leishmania amastigotes. Firstly, you can see this very spherical structure, and you do not see the typical basophilic nucleus and kinetoplast that you expect of leishmaniasis. Instead, these are fungal yeasts. And initially, I actually thought it was going to be Histoplasma capsulatum, but I should have noticed the sort of empty-looking spaces and mucoid material in the surrounding tissue. And the Grocott silver stain confirmed that this was actually Cryptococcus with this very wide variation in size of the yeast. And our MUC carmine stain confirmed the positivity. And in fact, we also sent a sample of FFPE curls to the Bristol Mycology Reference Center, where they confirmed on PCR that this was Cryptococcus. Our next example is where the pathologist sort of reached the diagnosis halfway, but did not make an attempt to subtype the organism. And more importantly, that message failed to get through to the clinical team that this was something important. So this was from an 88-year-old woman who now has very large umbilicated and exophytic vulval masses, which were first biopsied 6 months ago, and they were much smaller, but have progressed in the last 6 months. So this is the biopsy from 6 months ago, and they had diagnosed granulomatous inflammation with fungal spores. And here at low magnification, you can see the squamous epithelium on this side here. It's ulcerated. Underneath it, there's a lot of inflammation. And within that, we see these giant cells and macrophages with fungal spores. So they were correct. They were fungal spores, but they did not take it any further. We do a Grocott stain now, and you can see that the fungal spores are all quite small and uniform, bunched together. That means in the cytoplasm of macrophages. And we thought this was probably Histoplasma capsulatum. And that was again confirmed on by PCR on FFPE material. So obviously by now she's progressed, and we don't know what message went to the gynecologist 6 months ago, or actually if they did get the message about that. So this is not only about refining the diagnosis, it's also about knowing the importance of what you're diagnosing and alerting the clinical teams. My next case is where we are able to offer a more specific identification of an organism, and this is purely on morphology and actually just on an H&E. So this was from a 51-year-old woman who presented with an isolated raised ALT. An ultrasound scan of the liver showed a cluster of lesions in the right lobe. And these are the core biopsies, a very good core biopsies, and the original diagnosis was of a hydatid cyst. And this is, they're sort of halfway there again, so almost correct, but this is not cystic hydatid disease. What you can see is a very typical appearance of necrosis in the cores, and then these circular arrangements of laminated layer, which are diagnostic of alveolar hydatid disease. And that's confirmed on a PAS stain, which highlights the very small circular arrangements of the laminated layer. So this is Echinococcus multilocularis, not Echinococcus granulosus. And as you know, a completely different implication for the patient and their management. My next case is again where we offer a more specific diagnosis, but this time using molecular diagnostics. So this was from a 45-year-old Indian man from India who was diagnosed on imaging with a right pelvic and groin soft tissue mass in continuity. And this was diagnosed in a cancer center. And on these core biopsies, they correctly diagnosed a fungal infection. So you can see here very large multinucleated giant cells, a lot of fibrosis, and look at the eosinophils. We'll come back to the eosinophils in a minute. So on their PAS stain, they correctly saw these fungal hyphae, and again seen on the Grocott stain. So what we did is we sent curls for PCR. This is not something that when we just see a few hyphae like this, we cannot speciate. We can say what it's not. Doesn't look like aspergillus. So it's certainly not zygomycetes. But apart from that, there are very large number of fungal hyphae, environmental hyphae that could look like that. We need PCR, and on PCR, this was diagnosed as Trichophyton interdigitale. So we don't take all the credit for this, but I would say that we do add some extra value even on the morphology, in that they had said in their report, with the florid eosinophils, we cannot exclude a concomitant parasitic infection, whereas eosinophils you do see with fungal infections, and we saw no reason to suspect that there was another infection in addition to these fungal hyphae. So we were able to reassure clinically that these fungal hyphae are the important thing, are pathogenic and are causing this mass. My penultimate case is one where we are able to offer a more accurate or correct assessment of viability of the organism. So this was from a 32-year-old man who had been in Malawi 14 years previously, presented with hematuria, and the previous bladder biopsy had been diagnosed as probable schistosomiasis, and he had been treated with praziquantel. So this is the current bladder biopsy. There's urothelium on the surface, and the lamina propria is expanded by these very obvious nodules, which are hyalinized granulomas. And when you see hyalinized granulomas, you know the ova are not going to be viable. These are the ova, and I think what the original histopathologist was looking at here, who diagnosed this as viable ova, are the nuclei within the ova. The nuclei, however, are really pycnotic, and you can see this in non-viable ova, and that was our diagnosis. We also did a ZN to try and help with speciation. It's negative, which tells us that it's S. hematobium. So our review diagnosis was of non-viable ova, and just to show you some viable ova, this is another case, and the nuclei are much more plump. Cytoplasm is reddish, the nuclei form this corona, and look at the reaction pattern when you have viable ova, loads and loads of eosinophils. The other thing we always do is do a ZN to try to speciate, and this is a gut case, and you can see a pink hue to the shell and to the spine, and that's a lateral spine, so that's S. mansoni. So just like you, when you receive a referral letter, can tell whether the person who wrote it knows what they're talking about in infectious disease medicine. When we see a report, we know whether the pathologist who did it knows what they're talking about with infectious disease histopathology. And with the schistosome case, the two things we look for is, have they tried to assess the viability of the ova? Secondly, have they tried to speciate? So my final example is one where the pathologist has got the correct diagnosis, but what I feel we add is added value to enable you to manage your patient correctly. So this was from a 30-year-old woman who had a diffuse skin eruption in addition to fever, sore throat, and arthralgia. The clinical differential diagnosis was between Sweet syndrome, erythema nodosum, pyoderma gangrenosum, and they also added in rule out leprosy. I can't remember where she was from, and they took a punch biopsy from the right upper arm. They correctly diagnosed epidermolysis leprosy. So if you go to these photomicrographs, you can see here a nerve with vacuolated macrophages within it, and on the Wade 5 stain, fragmented acid-fast bacilli in those macrophage vacuoles, which is diagnostic of leprosy. But going back to the low magnification H&E, beneath the epidermis, there's this band of striking edema, and in the subcutaneous fat, there were collections of neutrophils. So putting those together, that tells us the patient is in an erythema nodosum leprosum or ENL reaction. This is our BCG immunostain, which also highlights a mycobacterial antigen. So obviously, diagnosing that reactional state has a huge implication for the patient, and hopefully with prompt treatment can save some of their nerve function. So my conclusion is, please gently ask your histopathologist to send the case for a specialist ID review if you are sure there should be an infection or organism in the histopathology specimen, but they don't see any. Secondly, if they report an infection or organism and you don't think there should be one. Thirdly, if they've identified an infection, but the infection they've identified doesn't fit with the clinical picture. Fourthly, they identify an infection, but do not provide you with enough information for you to manage your patient. And lastly, if their report is just too vague to be helpful, for example, granulomas not otherwise specified, correlate with microbiology. My thanks to our infectious disease histopathology team, so Professor Sebastian Lucas, from whom I've learned all my infectious diseases, Dr. Alex Polson, and Dr. Vivek Sekhawat, our stage 4 registrar, all the histopathologists who've referred cases, and you, the ID community, who have encouraged them to do so, and to Mike Brown and the remaining, the rest of the HTD team for your continuing support. Thank you.
Thanks very much, Ula, and you've really given a flavour there to our Wednesday afternoon meetings. And what often happens at that is Peter, there's often a parasite to be shown, and Peter asks everyone in the room to try and guess what the parasite is. And fortunately, he says, let's ask the registrars first. And so the rest of us can scratch our heads for a while. But I'm beginning to get a little bit better and sometimes a little bit worse at it. We've got a little bit of time for questions. Do please raise your hand or put a question in the chat. But I was hoping that we would have, which we do have, a little bit of time just to have a discussion about some of the issues that, Ula, you've brought up about the importance of this as a specialty. And also, we'd be interested to hear from those of you on the call as to, do you feel that you've got a good service locally, if you want to mention some cases that where you've noticed a difference. And I thought I might start off by asking Alex. Alex, you're quite relatively new to infectious histopathology, having specialized in another branch. Do you want to just tell us a bit about how that came to be for you and how you fit it in, and what you see as a sort of potential for developing a network of colleagues like yourself and Vivek, who I think is on the call?
Thank you, Mike. For me, it was a very spontaneous decision. When Ula asked me one day, and I had a bit of capacity, I don't think I realized at the time what a challenge it would be, for exactly the reasons that Ula described. I've been a consultant here for 10 years in my areas of expertise, if you like, which is gynae and urological pathology. And I thought, well, I'm reasonably confident with that. How difficult can it be? And I have to tell you, about 4 years later, it is still very difficult. Not only because my training in, well, there was no training in infectious diseases. It was just incidental cases that you pick up here and there. When you go through the different areas, but also what I find quite difficult is I rarely get to assess tissue from the areas that I know. So it is still, after all these years, I find it difficult with lymph nodes and brains. Yeah, so it is early days for me. And how about the network? Well, I think this is probably the way to establish it, that it has to come from the bottom up, sort of clinician driven.
Yeah, I completely agree with what Alex has said, and I do think histopathologists generally, our personalities are, really sort of backroom boy type of people, boys and girls, and really even when nothing changes in histopathology unless it's clinically driven. And so I do GI histopathology and cytology, but I enjoy infectious disease more than anything else, even though it's a very small part of my job, as it is Alex's, because for me it's knowing that few other people do it, so I feel valued, and secondly it's the clinical interaction.
Thanks both. I'll follow up with another question later, but there's one from Michael Marks in the chat to both of you. Is what do you think your national histopathology colleagues know the service exists? So what's your sense about the penetration of knowledge of access to your or other infection histopathology services in terms of knowing how to get stuff to be seen by the right person?
Well, like if I can start, I can say that because I sort of inherited this from Sebastian, and Sebastian was so good at promoting histopathology and talking. So we still actually get letters referred, Dear Sebastian. So I think Sebastian, so people know Sebastian and that he was doing infectious diseases. That's how it comes about. I'm not sure about the younger generation. I don't know, Alice, if you want to take that up.
Yes, I don't know either. What I'm struck with is, since I'm not aware of any other service like ours in the country, there are big parts of the country that we never get referrals from, and whether they actually have something similar that we're not aware of. But even that, I'm sure, would have fed through at some point to the HTD. So we maybe get a referral from a new place, and then quite a few soon afterwards from that pathologist colleagues. But yeah, I think the service is not well known. I'm also worried with all the issues that Ula mentioned about funding and how the NHS works, whether when we're well known, better known, how we will cope.
Okay, so one of the things there's a little bit of work being done with Mike Osborne at the President Royal College of Pathologists and with BIA colleagues, and it could be in the next round of the BIA survey in a section that's focused around diagnostics. We're going to survey people to ask what their routes of referral are. There may be fantastic other ID histopathologists around the country, and we'll work out how to help support it as a crucial service for the future. But I suppose I might ask Ula, from your experience when you went to CDC and from what you've seen and what you experienced, where the gaps are, what do you see as the kind of sunny uplands of infectious diseases histopathology? What would you like to get to? What sort of tools do you want? What kind of support does it need?
Yes, so I mean that model to me really is the ideal one, in that so a government-funded specialist infectious disease unit where you have histopathologists working alongside veterinary histopathologists, and veterinary pathology is absolutely fascinating, and because they're government funded, they're able to maintain a repertoire of immunostains, very wide range. So even if they only use it once or twice a year, they still have the antibody because they're not having to pay to keep it and then it expires. And the other thing about the CDCs, they have animal houses. So when a new infection is discovered, they get some antigen from a patient who died, and they actually make antibodies and make new immunostains, which things like when COVID started and so on. That sort of expertise is really internationally renowned.
Great. Okay, well, we're getting towards the end of the hour. Thank you very much for the thoughtful stuff at the end. And as I say, there is some work being done, but I think we need help from the wider ID community to bring that to the sort of national service that's fully recognised and fully supported. And that, Alex, you don't have too much work on your plate. And thank you for sharing some really fascinating pictures, which, as I say, are our bread and butter now at our monthly meeting. anybody who wants to refer a case, do get in touch either directly to us at HTD or directly to Ula and Alex in the pathology department at GSTT. We look forward to seeing you all next month. So 4th Thursday of the month, it'll be an October session. And I think, if I'm right, that's going to be all things fungi. So do join next time and do spread the word about these sessions as well.
Thank you very much, Mike. Thanks, everyone.
Thank you very much.
Good. Thanks all. Bye.